This is an introduction to the Ranger warmer, the 3M pediatric warmer for fluid that we're going to use in the emergency department for pediatric MTP or mass transfusion. This is a new product for us, moving away from the hot line. It is a low priming volume, fast warming set that allows us to rapidly infuse crystalloid or blood products for children who are in need of MTP. Really simple system. You've got a cassette or cartridge, which must be inserted dry. You can't fill this with fluid first and then insert it. You take it out of the packaging, you'll see a little bit of a diagram on the front, 1, 2, 3. Real simple, it just slides in the front, just like a tape cassette. It has 2 lines for priming. Blue goes to bag, red goes to patient. I'm gonna close all of my roller and click clamps. I'm going to assemble a manifold, or if you have a ready-made manifold for allowing you to attach 3 different fluids. We're going to start with saline, RBCs, and FFP. And this allows us to have multiple fluid types come through the same line individually. Make sure that your connections are snug. I'm going to have my saline come in on the end. And then my RBCs and FFP hook up as well. I'm going to do this with aseptic technique, so I'm going to swab all these connections prior to hookup, of course. But for clarity and speed, I'm not doing that now. So again, I've got my RBCs, FFP, and saline. I'm going to prime the system with saline and getting my lines out of the way just so you can see. So my stopcocks are open to the saline right now. I'm going to open up my saline set. This is primed already. I'm now going to open up to the bag, allowing fluid to flow through the system. This bubble trap, which is this large canister, I'm going to invert vertically. And I'm going to open up this last click, and you'll see fluid start to flow through. Once this bubble trap is full of saline, I can then invert it again so that it sits properly to go into that side clamp. I'm actually going to clamp this here briefly. Insert the bubble trap into this side holder, and that will stop any significant bubbles from making it to the patient. And I'll have a trash can here to continue to prime to the end. So that could be hooked up to the patient at this point. I'm going to hit my clamps again just to make sure that everything is sealed. In order to warm this set, all I have to do is, there's a single button, real simple, only one button that flips on the side. Has to be plugged into work. It has no battery backup, so you need to have it plugged in. It'll tell you the initial temperature, and it should reach its infusion or transfusion temp of 41 to 43 degrees within 2 minutes. It's pretty fast. That 40 ml priming volume is from our connection to the end. It's 39 mLs. The pediatric set, if you have access to that, is 20 mLs. That's good to be aware of when you're drawing from your stopcock using the push-pull method at the patient side, that if you are pulling, it's going to be 40 mLs, that you're getting through that whole set. While this is warming up, depending on the size of patient that you have and your institution's policies. Of course, our crystalloid boluses for pediatrics are going to be 10 mLs for neonates, 20 mLs for all other peds. For blood products, standard is usually 10 mLs. In mass transfusion, depending on your institution, you might be 10, 15, or 20 mLs per kilo. Here at UVM, we are currently using 15 mLs per kilo. That's per our policy NCRIT 46. What you'll do is have a product dosage based on weight, and you'll figure that out based on a 5 kilogram increment from 5 to 40 kilos, and you'll fill that in on our MTP sheet. You will be getting enough blood from the blood bank for each round, but you're not getting an exact volume. You're getting enough blood in bags to complete that dose, and then you will have to measure and administer that dose based on that child's weight. So you'll notice that this, in that 2 minutes, is already warmed up to 41 degrees. If it overheats, it'll alarm. All you have to do is turn it off. Turn it back on, it'll warm right back up. So just, usually if it overheats, I'll give it a couple of minutes, and that is uncommon. It doesn't happen very often. For administering doses at the patient side, we're going to attach a stopcock, and then depending on your patient size, you're going to want either a 20 or maybe even a 60 ml syringe. I'm opening up all these to gravity now. Just flushing my stopcock. For removing fluid or pulling fluid through the Ranger warmer, the pediatric set can warm at about 100 mLs a minute. The adult set can warm at 150 mLs a minute. So know that if you are filling up, say a 20 ml syringe, you should do that over 10 seconds or so. Nice, slow, gentle. So right now I am off to the patient. I'm going to gently pull maybe 10 seconds for every 20 mLs. Nice, easy pull. I'm not moving fast. You may see the occasional bubble come through your tubing based on how fast you're pulling. And if I look at my bag here, that's a constant stream, but any bubbles are going to be caught in that bubble trap there. So that's just something to be aware of. But anytime we're doing mass transfusion, you're just aware of being careful of any bubbles so that they're not administered into your patient, at least large volume air. I have 60 mLs here. I'm now going to go off to a line, and I'm going to use that push-pull method to slowly transfuse or infuse into the patient. I often place my hand over the catheter on the patient's skin so that I can feel the sensation of fluid flowing through their vessel, and that way I know that I'm not pushing too fast, and I can be careful for extravasation, make sure that line is still patent. I go off to my patient. At this point, if I wanted to give a different fluid, it's helpful to think about that beforehand. So instead of, say I know that my next round is going to be RBCs versus FFP. So right now, say I'm gonna give RBCs, so I open up my RBCs, I turn off my saline. It can be helpful, granted we're using fake colloids and crystalloids right now, so the colors are tough to see, but maybe label your lines in good ICU fashion so that you can see which are which. And at this point, I also have to look back at my manifold. So I'm going to make sure that I'm off to my other fluids. I am just on to my RBCs, and I'm gonna start pulling now. And you can probably see up above that as I'm pulling, they are coming from my RBCs. Oh, I'm kinked up here, pardon me. There we go. So you can see a constant stream coming in from my RBCs. Nice, slow, gentle pull. Because of that priming volume, the first 40 cc's that I pull out of here is going to be saline from my last one. So that's where it's helpful to anticipate what your next fluid's going to be. You'll see that pink tinge here. Crystal light RBCs. Slow, gentle transfusion. And I'm giving 60 mLs of fluid now. Off to the patient. And at this point, this is all RBCs. There's no mixture with saline. I will often take a piece of tape or a label and either put it on the barrel of my syringe or on the table, or sometimes on my pant leg if I'm seated while I'm giving this. And I mark each syringe full of fluids as I give it so that I have a total volume given for each round. Nice slow infusion, and that feels warm to the touch. So even with this pretty fast push-pull method, those fluids that were room temperature are now warmed up to 40 degrees C. So if I wanted to give one more of RBCs, say 20 more, I'm going to pull here, and then at the 20 mark, because I'm using a 60 cc syringe, I'm actually going to pause my RBCs. I'm going to open up my FFP. I'm going to go back to my manifold, turn off my RBCs, open up my FFP, and now as I pull, we're gonna have kind of an admixture here of RBCs and FFP, but that's anticipating that I'm switching halfway through there. You'll also see that I've got a full stream off my FFP bag. It's important to note that the nurse who is administering this is their only job. They are just focused on this. They should not be checking blood. They should not be administering other drugs. They should not be documenting. They are just focused on giving the appropriate amount of fluid over the appropriate amount of time, assessing the patient, assessing their line. This is now just FFP at this point because we have cleared the RBCs from that priming volume. And these doses would just be based on patient's weight. When you're done, say, so I'm at that 20 again, you would want to clear with saline. You don't necessarily have to clear into the patient. So if you wanted to disconnect, you'd give in all of the FFP or all of the RBCs. If you don't want excess crystalloid fluid, you could disconnect your line from the patient at that point. You could just turn on your saline. And hardest part of this whole process sometimes is line management, so just being aware and taking the time to say, oh, I've opened up that line, but I have to go back and make sure that I have changed my manifold or my stopcock as well. The other benefit of using a syringe like this is that it also acts like a bubble trap. Granted, we're in a closed system, so it wouldn't be an issue, but if you were detached, you'll notice that that will hold those bubbles there. So I'm flushing the system with saline right now so that I don't have an admixture within the set. Small pauses in transfusion are fine, but for any lengthy period, they should just have saline in your system. You shouldn't leave blood or FFP there. This information can be accessed through the UVM system, through our policy. Currently, that's NCRIT 46 for pediatric mass transfusion. You can see videos on how to use the different products on 3M's website. We're using the Ranger warmer in adult and pediatric sets. Again, the 20 and 39 ml prime volumes. And we are only giving RBCs and FFP through this. Your platelets and your cryoprecipitate, of course, are just given, also weight-based, but just given room temperature, either to gravity or with a push-pull method. Thank you for watching.